this session, Dr. Santoshi, Dr. Anand Krishnan, Dr. Sabnish, Dr. Anish Srivastava, Dr. Kishore T. and Dr. Keshav Murthy to please come on the dais. And with this, I would like to invite the first team, I should say, because now this session will have one talk, but the one talk, there are two persons who will be taking, coordinating with each other with this talk. The first team is from Max Sake, Delhi, Dr. Tushar and Dr. Harshit. I would like to invite them on the stage for their talk. And they will be speaking on Neoadjuvant HT plus chemo or ARTI. Over to the chairpersons for the next session. Dr. Anand.
Hi, good morning, everyone. Many thanks to the organizing committee for giving us this opportunity. We'll be speaking on neoadjuvant therapy for high-risk localized prostate cancer. That's before radical prostatectomy or radiotherapy. And Dr. Harshit from Max Vaishali would speak about hormone therapy, and after him, I will take on the androgen receptor signaling inhibitors, that's abiraterone, enzalutamide, and other drugs, and neoadjuvant chemotherapy in prostate cancer. So I would request Dr. Harshit to start off, and then I'll come in.
I respect chairpersons and dear audience. Very good morning to all of you. It's an honor and pleasure to give the first talk for this session with the house full. So I think let's get the ball rolling. We have seen the wonderful prostatectomies down the line, and now in the dilemmas in the management of prostate cancer, neoadjuvant hormonal therapy plus chemotherapy or ARCs or whatever it is, and so basic outline. We'll talk about rationale, current guidelines, what is the evidence of use, duration, and the novel agents. So this Charles Huggins and Hodge, they were the guys from University of Chicago who laid the foundation in the prostate cancer management, and they eventually got the Nobel Prize later on for for doing a simple orchiectomy or hormonal suppression as a treatment of prostate cancer. So this is where all this started, around 60, 70 years ago, and from them, gradually, we have used this ADT in almost every setting. It's evolving. We have got newer agents. We have got so many things in our armamentarium. And so as we have more and more options, we are also changing our settings. And so there's the neoadjuvant setting in the prostate cancer. But let's get to the basics. Before we start, let's take a quick look at the, what are the current guidelines saying so that we can have a discussion later. European Guidelines 2024 very clearly say do not offer neoadjuvant ADT before surgery. They're very clear with a strong recommendation. NCCN says neoadjuvant ADT for radical prostatectomy strongly discouraged. Okay, that's the best scenario. What does the Indian guidelines say? So these are the guidelines from the USI, and they also clearly mention that neoadjuvant ADT is not recommended. So if there is a strong recommendation, there is so much data and evidence supposedly, then what are we thinking? Why are we thinking of neoadjuvant setting in prostate cancer? One, because we have got a lot of new novel agents, and number two, in the times of COVID-19 pandemic, we have a lot of studies, we'll have such a glimpse on, where people have given, some medicine so as to delay the surgery because we are not able to operate those patients upfront at the time. And that, revamped the interest. So let's go start. What is the rationale of a neoadjuvant, therapy in prostate cancer? You can treat the occult mets or disease. You can improve the local disease control by downstaging, and you can also have an idea about the response to therapy, which would give you prognostic information. This is basically drawn from all other, cancers neoadjuvant concept. So this was proven with the radiation therapy, and in radiation therapy there is strong evidence that neoadjuvant ADT is preferred. Even now they are debating between neoadjuvant and concurrent, but there's still robust evidence that neoadjuvant ADT works for the patients who are undergoing primary radiation therapy for prostate cancer. But why do they think so? Because it sensitizes their cells by downregulating their DNA repair. But can that be extended to surgery? Maybe not. And so we had a lot of trials starting from 1993 from across the globe, particularly from the West though, that all type of agents, mainly GnRH agonist, with numbers ranging 100 to 200 patients, with a follow-up ranging from 3 to 5 years, and all of them have shown that it has not much benefit. And this was systematic review published in 2009, which include 10 studies with 3 studies single agent, 7 studies combined blockage, and what they found that yes, the neoadjuvant ADT decreases the positive surgical margins, improves the rate of organ confinement, decreases the rate of positive lymph node, but there was no benefit in overall survival or disease-free survival. And that was the prima facie why all the guidelines are saying that neoadjuvant ADT is not to be recommended because there is no survival benefit. And this paper, particularly from Japan, published in Prostate International in 2018, it rather showed that neoadjuvant ADT showed a potential deleterious effects in older patients. They have a poorer biochemical recurrence survival, and especially in those patients with the lower testosterone levels. So all these things, were worrisome that, we should not give neoadjuvant ADT. And then during the COVID times, this paper, examining some data from the United Kingdom, about 37 patients in the COVID cohort received the neoadjuvant ADT because they delayed the surgery. And yes, they showed a trend because sample sizes are small, but they showed a trend towards reduction in positive margins, N1 and pathological downstaging. But actually, when they followed these patients, they actually had higher PSA after surgery, the early recurrence. So that is all what is, neoadjuvant is saying something that, it doesn't improve the biochemical recurrence-free survival. Second question when we talk of neoadjuvant is duration of ADT. So yes, 3 months of ADT, normally, you give an injection and you just wait for 3 months. That's the general standard because what is found that it decreases the prostate volume by 20 to 50% and PSA levels by more than 90%. Longer study a duration of 6 to 8 months have been studied in 3 studies, and the review combining these their results show that yes, they decrease the positive margins if you have longer than the 3 months of ADT. Yes, they have a better organ confinement rates, but there is of course no data on survival outcomes because these studies did not assess the survival outcomes. So this is a latest review from Davos from Sweden. What are and there is some valid concerns like with the neoadjuvant ADT because there is we don't know what is the pathological response after ADT. We don't know how the hormone therapy affects the prostate tissue, and it can actually lead to early onset, selection of the cells for CRPC, and that also supports because there is a very low proportion of pathological complete response. While in bladder we have much better PCR after neoadjuvant, such rates are not there in the prostate cancer. So all this being said, let's come to the options for the ADT, neoadjuvant ADT we have. Like we have conventional ADTs, we have novel receptors, we have chemotherapy, immunotherapy, and other novel agents as well. So I'll talk about conventional and then I'll hand over the mic to my colleague. So in conventional, we all know agonist, antagonist, combination, non-combinations. That's a very basic thing. And we have been using conventional agonist and then antagonist came in. This was the study basically which summarized that antagonists have lower cardiovascular effects. That's why antagonists were preferred. And this debate always is there, agonist versus antagonist from Neil Shore versus chemo. There are beautiful editorials in these journals during 13, 14. But do we have a definitive answer that which is better? For surgery, I'm not sure, but this data from radiation therapy where they compared agonist versus antagonist is the largest randomized trial published in JCO. And what they found that when you give both either degarelix or you give goserelin, prostate shrinkage is similar, but IPSS score reduction is higher in the patients with degarelix, and that too particularly in those patients with a higher IPSS of more than 13. So, but do we have a definitive answer for patients prior to surgery? And I don't have a good answer for that. Having all said done, as we are now transitioning to the newer agents for the neoadjuvant therapy, we shall always remember in this editorial that it is critical to emphasize that neoadjuvant approach is not a standard of care, but it is important that it is needed in high-risk cancer because these are the men who are at the greatest risk of relapse and morbidity. And so that is the need of the hour, that you need to find some agents which could improve your survival, which are both biochemical and overall survival in high-risk localized prostate cancer before surgery. And with that, I thank you and would call upon Dr. Tushar to continue the talk and take us towards the newer agents in the neoadjuvant ADT.
Can you have the slides, please? Yeah, it's on here. I can see. It's on my screen. Okay, till the time we get the slides up, till now what we know is hormone therapy in the neoadjuvant setting just improved our pathological surgical margin rates. It downstaged the tumor, decreased the lymph nodal involvement rates, but it failed to show an overall survival benefit, a cancer-specific survival benefit, and a recurrence-free survival in prostate cancer patients. And that is the reason why none of the guidelines do advocate neoadjuvant therapy. There are quite a few reasons for this. One, the trials which have been with neoadjuvant hormone therapy have not been powered enough and have not followed the patients long enough to show a biochemical recurrence-free survival and overall survival. Also, there are other pathways other than just the testicular androgen receptor signaling that results in growth of the prostate cancer cells. There's intratumoral androgen production, and there's androgen production from the adrenal glands. So this is where the other agents, abiraterone, enzalutamide, comes into picture in the neoadjuvant therapy. So I'll start off. I'm Tushar Aditya Narain. I'm a senior consultant at Max Smart Hospital, Saket. And today I'll be talking about neoadjuvant second-line therapy. So Harshit has already covered all of that. So I'll just tell you what is ARSI. ARSI is a term, androgen receptor signaling inhibitors. So these are the second-line anti-androgen therapies. The most common ones are abiraterone, enzalutamide, apalutamide, and darolutamide. Now, why are we considering these ARSIs and chemotherapy in the neoadjuvant setting? Because we have a lot of data from the metastatic and the castrate-resistant setting that these agents, when added to hormone therapy, do bring about an improvement in the overall survival. Stampede trial, Charted trial, Latitude trial, all of them showed that these agents improved the overall survival in prostate cancer patients. Before starting off with these agents, I wanted to focus a little on the basics. This table shows the different mechanism of action, and that is the reason why only LHRH agonists did not probably have a survival benefit, because other pathways inside the prostate cancer tumor cells and the androgen produced by the adrenal gland were still active. So for example, abiraterone inhibits the enzyme in the adrenal gland and inside the prostate. Enzalutamide inhibits the androgen receptor. It also inhibits the translocation of the receptor inside the nucleus. So these are the different pathways that were still functional even with the normal ADT during the neoadjuvant setting. Any tumor, when is a tumor suitable for a neoadjuvant therapy? There are certain criteria which should be met, such as for bladder cancer, neoadjuvant therapy has been well established. The criteria that are that there should be an adequate local therapy for that tumor. There should be a substantial risk of recurrence if there is no neoadjuvant therapy after the local therapy. And there should be effective drugs that are available to treat the specific time of tumor and the micrometastasis. And prostate cancer checklists all these three criteria that should be there for any tumor that is eligible for neoadjuvant hormone therapy. Now coming to ASRI and chemotherapy, as I already said, there are other pathways of AR signaling that are still active in spite of normal hormone therapy. So, and that is the intratumoral testosterone that is produced inside the prostate cancer cells and non-testicular sources of testosterone that is coming from the adrenal glands. So hence, these drugs are now being tested along with hormone therapy in the neoadjuvant setting. So now let's go to the exact drugs and the trials that are underway. Not a lot of trials have been done, only few randomized controlled trials are available for different drugs, but they have had some promising results. For abiraterone, this was the first trial in 2014. This was a randomized controlled trial that evaluated the role of abiraterone along with leuprolide versus leuprolide alone. And they showed, this was a randomized controlled trial, about 30 patients in each arm. They did a biopsy at 3 months in both the groups. And the biopsy showed that the level of the intratumoral testosterone, DHEA, testosterone, progesterone, all was lower in the combination group as compared to the only LHRH agonist group. So this proved that abiraterone lowered the intratumoral testosterone level, and this supported the hypothesis of the functioning of abiraterone in addition to LHRH. And they concluded that when abiraterone was added to LHRH, the response rates, the PSA response and the pathological downstaging was much better as compared to LHRH alone. So this was the first study. This paved way for further randomized controlled trials. This trial was published in about 2019. This was a phase 3 trial. And this again showed that the tumor epithelial volume and the pathological stage was better when abiraterone was added to LHRH, although the 3-year recurrence-free survival was not significantly different. So this trial again did not show any survival benefit, but the pathological endpoints were better when abiraterone was added to hormone therapy. So this was for abiraterone. Coming to enzalutamide, this was a phase 1 feasibility study of neoadjuvant enzalutamide prior to prostatectomy, and they also concluded the same thing. Pathological end results were better when enzalutamide was added to hormone therapies. This was a randomized phase 2 trial of enzalutamide with abiraterone and hormone therapy, and this trial showed that adding abiraterone and enzalutamide together did not improve any further benefit to the pathological downstaging. So one ASRI with hormone therapy is enough. You don't need to add another ASRI to the hormone therapy. That means if abiraterone and ADT are being given, there's no benefit of adding enzalutamide. Coming to apalutamide, this was a near trial which was presented in AUA in 2019. Again, a phase 1 feasibility study, patients, single arm study. Patients were given apalutamide daily for 12 weeks, followed by radical prostatectomy. They concluded the same thing. Pathological end results were better when apalutamide was given. These trials were not powered to show any improvement in cancer-free survival or overall survival. So this is another trial of apalutamide plus abiraterone plus leuprolide, and this also showed that dual androgen sensitivity inhibitors does not further improve outcomes. So one inhibitor plus ADH is enough. You don't need to add another one. Another randomized controlled trial of intense androgen deprivation. Intense is apalutamide, abiraterone plus leuprolide versus abiraterone, prednisolone, leuprolide. So this is again 2 inhibitors plus ADT. And then they also showed that the pathological response were similar between the 2 arms. Addition of one more inhibitor did not improve. So basically the take-home message was that one second-line inhibitor plus ADT was enough in the neoadjuvant setting. This is a trial which is ongoing. This is randomized phase 3, one of the largest trials till date for apalutamide. They plan to recruit about 2,000 patients. One arm will have apalutamide plus hormone therapy versus hormone therapy alone, and this would give us an answer whether apalutamide should be given in the neoadjuvant setting along with hormone therapy. So this is still recruiting. The last drug, darolutamide. So this trial is, I think, also undergoing. This is a multi-center trial with darolutamide with the same pathological outcomes. So the take-home message for the second-line hormone therapy is addition of a neoadjuvant second-line agent to ADT substantially reduces intratumoral androgen concentrations compared with hormone therapy alone. Non-castrating ARSI therapy, that means second-line hormone therapy alone without LHRH agonist is inferior because this results in a negative feedback and the testicular androgen levels go up. Hence, the results are not good with just second-line hormone therapy. You have to have a hormone therapy with the second-line hormone therapy. Maximal androgen blockage, that is 2 second-line agents, does not have any added advantage. And neoadjuvant second-line therapy is feasible and does not cause an increase in the intraoperative complications or severe treatment-related adverse effects. So this was our conclusion from the second-line therapies. Now coming to the chemotherapy. What's the basis for chemotherapy as a neoadjuvant chemotherapy in prostate cancer? We know docetaxel chemotherapy has good overall survival, cancer-specific survival in the metastatic setting. This is because it acts on the castrate-resistant stem cells. So it has been postulated that these castrate-resistant stem cells are present even in the initial stages of treatment, and docetaxel may be beneficial even in the neoadjuvant setting. This is the GTUG-12 trial, one of the first randomized controlled trial for docetaxel and ADT in a neoadjuvant setting. And this had about 800 patients, and this was the first trial which showed that neoadjuvant chemohormonal therapy had an 8-year relapse-free survival improved as compared to ADT alone. The difference was significant, and this was the first trial to show that there was an improvement in the overall survival. This was followed by another trial, which is a landmark trial in neoadjuvant chemotherapy, the PUNCH trial. This had neoadjuvant chemotherapy, neoadjuvant hormone therapy versus radical prostatectomy alone. You can see that the positive surgical margins, positive lymph nodes, pathological T stage are all lower for the chemotherapy, hormone therapy arm. But this did not stop here. This trial showed at about 6 years an improvement in the event-free survival, metastasis-free survival, overall survival, and a decrease in the prostate-specific death. So this trial showed that chemotherapy plus hormone therapy had overall survival benefit when given in a neoadjuvant setting. So I'll just hurry up, I have 1 minute left. This is another trial, the Neptune trial that is going on. This is for olaparib, a PARP inhibitor in high-risk prostate cancer patients who have BRCA1 and BRCA2, who are known to have high-risk disease. So this is being tested in a neoadjuvant setting. So my take-home message, high-risk prostate cancer is called high-risk for a reason, because if you just give local therapy, there are very high rates of biochemical recurrence. Even after adjuvant therapy, 50% of the patients will have recurrence in the next 5 years. Neoadjuvant hormone therapy downsizes the primary tumor and treats the micrometastasis at the beginning of the treatment. It improves the positive surgical margins, the local stage, but till now has failed to show any improvement in the hard oncological endpoints, that is cancer-specific survival, overall survival. Combination of neoadjuvant hormone therapy and second-line anti-androgens have added benefit because they have different mechanisms of action which are synergistic with each other. Neoadjuvant chemotherapy has been shown to show improvement in recurrence-free survival, cancer-specific survival, and overall survival over 8 years in 2 randomized controlled trials. What we need is further RCTs with longer follow-ups, and if we have that, probably we'll establish that neoadjuvant therapy is the norm in prostate cancers as it has happened in bladder cancers. And neoadjuvant therapy also gives us an opportunity for translational research in which we can pick up genetic markers, do the study, which patients respond to neoadjuvant therapy, and then go on for personalized medicine. Thank you for that, and I would end my talk here. Thank you very much. If there are any questions, I'll be happy to take some questions.
So Tushar, this is a very good talk, both of you. Now, would you like to continue the NAHT for a period of, continue the hormonal management for a period of 3 years? Would you think that makes a difference? Because in radiation, you continue it for 3 years.
3 years, yeah.
You're comparing radiation and surgery.
Yeah.
So would you like to continue hormones for 3 years as well? Do you think it makes a difference? Because, without hormone treatment,
yeah,
the biochemical recurrence, extraprostatic extensions are the best surrogates you have for long-term survival.
Right.
But why do you think it's not showing a difference here?
So I think for most of the studies, they have continued hormone therapy in the adjuvant setting for 3 years where they have done a radical prostatectomy. But yes, as you mentioned, biochemical recurrence is a surrogate marker, so I would want to stop at the local therapy site, follow up the patient with his PSA, and then see how he does.
I think very few of us are using neoadjuvant. It is not recommended right now. So we take the biopsy and after 4 weeks we do the surgery, So I'm not sure if you are giving an injection or some medicine in neoadjuvant setting, how actually, you plan to follow up the patient if you continue the therapy.
Anand, are you using neoadjuvant? Because I also have not been using neoadjuvant therapy for T3, T4 tumors. We go ahead, if it's resectable, the patient is obviously given an option about ADT and EBRT, and if he chooses surgery, I go ahead with the surgery, and based on the final histopathology report, the lymph node status, would I decide if he needs adjuvant or an early salvage radiotherapy later?
Good point. I'm going to ask the experts here the same question. Can you please weigh in on this, sir?
Yeah, there is one question from the audience as well. I'll just go before that. So isn't it true that the earlier report of the Proteus trial, they said that if you give 6 months of neoadjuvant hormone therapy, then almost 25% of the patients, they get complete response when there is no tumor left in the prostate.
True.
Considering the fact that if it is less than 5 millimeters, it is considered as a partial response. So isn't it a positive sign?
It is, absolutely. I agree with you. In principle, I agree. The positive surgical margins come down, the tumor is shrunk, the lymph node status has come down. It should reflect in an overall survival. Probably our follow-up is not so robust. The randomized controlled trials have not been designed. It's just a matter of time. That's what I feel, that this will start showing improvement in the cancer-specific survival and the overall survival.
Yeah, there is one.
Hi, Tushar. Hi.
Yeah.
Alok here. So is there any role of NAHT per se if you consider the size of the prostate in very large size prostates like greater than 150 grams or something like that?
No recommendation as such again for that, but then yes, logically we can go ahead with that along with dutasteride to decrease the size of the prostate just for decreasing the pathological outcomes and making the surgery easier.
So would like to ask the experts
We are running
here.
short of time.
Okay.
One last question from
Have you
Shahid.
felt that in those patients who have a T2 or T3 and high grade, if you have given your adjuvant and then you're going from, because many of these they don't want to wait for these 6 weeks, they're all perturbed, and very many of our colleagues just give a drug. Have you found that you have a lot of fibrosis and it's difficult at that time to even do the radical prostatectomy?
Absolutely. That's the reason
And
why
so, sorry.
I beg to differ with that. That happens only with bicalutamide. I have
Yeah,
seen.
bicalutamide.
Yeah,
But
the
they
rest
give-
of the hormones they won't cause too much
most of them come with having taken bicalutamide
Yeah.
and an LHRH.
Yeah.
So and then it becomes difficult to actually have a proper radical prostatectomy done. So if you are going in after 4 weeks and not 6 to 8 weeks, it's nice to counsel those guys, and then they seem to listen to you.
Thank you. We move on to the next
thank you.
talk.
Thank you, everyone.
Thank you.
Management of positive surgical margins by Dr. Puneet and Dr. Gopal Sharma.
Yeah, one request that we have to stick to time. So I request the speakers also to finish their talk in 15 minutes or so that we have time for discussion. And for people who have a lot of questions, we have live operative sessions. We can actually use that time to discuss questions as we go on. So let's stick to time.
Thank you so much, and good morning, everyone. I'm Dr. Puneet, and I have my colleague Dr. Gopal with me, and we'll be discussing about the positive surgical margins. What we'll do is that we'll have a case-based scenario, and we'll discuss the literature along with that, and go ahead. I would request my colleague Dr. Gopal first to start off with the case scenario. Then I would discuss some literature and try to answer some questions. And then Gopal again would discuss our results. Gopal.
Good morning, everyone. I am Dr. Gopal Sharma. So basically the theme of this topic is basically to highlight dilemmas and controversial areas, but I would say there is not much dilemma or controversy in the positive surgical margin after radical prostatectomy area because of few trials which were reported in 2020, which were basically radicals and raves, and it has primarily solved the area of margin positivity. And we had to delve into the literature to find out dilemmas and controversy. So hopefully using a case-based approach, we would be able to highlight common scenarios and how they are managed. So we have obviously fabricated these cases. These are we have one scenario in which there is one patient one which is who has history of LUTs and has some comorbidities, and PSA was less than 10, and then he had a Pirates 5 nodule in the left peripheral zone near the apex, and he had undergone fusion biopsy, and 4 cores were positive out of that, and PSMA PET was negative. So basically it is looking like a clinically T2 disease. And at the same time, patient 2 who has PSA of 15.8 and other PSA was 19.2, and he has 2 nodules, one at base and other at apex, and all the cores were positive. And he had extraprostatic extension and SVI on MP-MRI. So clinically he is at least CT3B. So both of them underwent radical prostatectomy, and post-op course were uneventful. So for patient 1 who was clinically T2, we have designed 3 scenarios, and on biopsy he had acinar adenocarcinoma, Gleason 3+4, pathological it was also PT2, and lymph nodes were negative. The first scenario is when biopsy came, it was unifocal positive surgical margin at apex, length was less than 3 mm. Second was unifocal positive surgical margin at apex, length was more than 3 mm And the third scenario is he has multiple positive surgical margins and largest was more than 3 mm. Now you would be wondering that we did not mention the Gleason score at the margins, but it is now not recommended to report positive Gleason score at the margin. So we have not reported that. So now I would request Puneet sir to comment on these 3 different scenarios and also on the patient 2 scenario who was clinically locally advanced. He was clinically PT3B, now pathologically it is also PT3B, and Gleason score is grade group 4, 4+4. All the lymph nodes are negative. Again, the same 3 scenarios. Scenario 1 is when single positive margin with less than 3 millimeter. Scenario 2, unifocal margin but more than 3 mm. And the scenario 3 is multifocal margin positive, both more than 3 mm. So over to Puneet sir to discuss the following questions.
Thank you, Gopal. So before starting off, I just want to know something from the audience or the chairpersons here. Is there anybody in the hall who is giving additional treatment or adjuvant treatment just to all the patients with positive surgical margin, just on the basis of positive surgical margin, to all positive surgical margins? You are giving to the all positive surgical margins, irrespective of any other criteria? Okay. So I think most of us agree that all positive surgical margins do not need additional treatment.
But can we, sorry Puneet, can we just rely on positive surgical margin? Because if somebody has got EP plus positive surgical margin, then definitely.
So that is why that I am just taking one criteria, just positive surgical margins. If you have everything else, there are various scenarios in that. So we will discuss that. But just if you have a localized disease and positive surgical margin, would you give? That was the question. So I think most of us agree that only positive surgical margin is not the criteria, and it's not a sinister thing to have. So
we can take questions after presentation.
Sir, we'll do the questions later, please.
So the questions which arise from the topic is that how does it affect how does the positive surgical margin affect recurrence-free survival in terms of biochemical recurrence-free survival and clinical recurrence-free survival, the mortality rates, which are the more important endpoints like prostate cancer specific mortality and overall survival, and then the additional question like whether it is important to know the Gleason score at the positive surgical margin, the location of the positive surgical margin, and which patients would need additional treatment. So to know this, first we should know that what a clinically meaningful positive surgical margin means. So EAU has divided this into a favorable and an unfavorable margin. So based on more than 1700 patients, favorable margin is a single margin which is less than 3 mm, whereas unfavorable margin is more than 3 mm or a multifocal margin. So when the recurrence rates was, we are trying to address the first question with this, the recurrence rates, biochemical recurrence-free survival and the clinical recurrence-free survival. So when the recurrence rates were studied, so it was seen that the biochemical recurrence increases with any degree of positive margin, with the length of positive margin, as well as the focality of the positive margin. Whereas if you consider clinical recurrence, which is a more important endpoint, only patients with positive multifocal margins had more clinical recurrence rate, or more than 3 mm had more clinical recurrence rate. That means patients with an unfavorable positive margin had more clinical recurrence, whereas with favorable positive margin, which is less than 3 mm, clinical recurrence did not increase. So now whether it stands true for all the patients, like for the patients who are T2 versus T3, or the patient who had non-adverse pathological features versus adverse pathological features, the answer is no. Even in the patients who had unfavorable margin and also, but they had non-adverse pathological features that is less than T3A disease and grade group less than or equal to 3 and no nodes positive, even having an unfavorable positive margin that is more than 3 mm or multifocal margin is not going to increase clinical recurrence. Biochemical recurrence is different thing. It increases in all the cases. But clinical recurrence does not increase in unfavorable in patients who have non-adverse pathological features. But patients who have adverse pathological features like PT3B or 4 or pathological grade group 4, 5 or lymph node positive disease having an unfavorable positive margin, it increases clinical recurrence. Now, how does it translate to, so the answers to the first question is that yes, BCR increases, but only men with adverse pathological characteristics and unfavorable PSM were at increased risk of experiencing metastasis. So how does it translate to the mortality rates? So whether mortality is also high in these patients or not. So again, in patients with adverse pathological features, having a multifocal positive margin lead to increased cancer-specific mortality and overall mortality. You can see on the curves, the lowest line, which is a red line, is a multifocal margin. It is important to note here that unfavorable in the first case scenario where it was more than 3 mm does not actually leads to mortality. It can lead to clinical recurrence, but mortality, multifocal margin, and that too only in patients with adverse pathological features is important. So it is important to avoid multifocal positive surgical margins in patients with adverse pathological characteristics, and these are laid down here. So like Dr. Gopal said, the importance of Gleason score at the margin. So it is not very important, it's not given in many guidelines also, but there are studies which have tried to evaluate this. So BCR free survival, metastasis free survival, and cancer specific free survival, they all go down in patients who have Gleason 4 versus Gleason 3. Now it is important to note that this study which had all the patients who had pathologically T3 disease. So whether these survivals are going down because of the Gleason score margin at the margin, or whether it is going down because of the inherent aggressiveness of the disease, we don't know. So similarly, location, this is just evaluated on the basis of biochemical recurrence, having a positive surgical margin at apex or a multifocal do much worse as compared to negative surgical margins. So these questions I've tried to answer is that Gleason 4 is bad at the margin, and apical or multifocal is a bad margin. Now, ultimately, how does it translate into our practice? What are we going to do? So what is the need for additional treatment? So there have been 3 randomized trials which the subgroup analysis of these trials have tried to evaluate the benefit of adjuvant the radiation therapy in PSM, like EORTC trial, SWOG trial, and German. These are old trials, 2005 and 9. So they said that it is important to give consider some additional treatment. But still in EORTC trial, when the adjuvant radiation was given, these patients, most of the patients have a PSA of more than 0.2. So in effect, it was actually a salvage radiation therapy rather than a adjuvant radiation therapy. So coming back to our original questions, considering all this literature, in the first patient who has a T2 disease, biopsy scenario of 1, 2, and 3 all, whether any length of margin or any multifocal, you can observe. Whereas in second patient, the last scenario, we would tend to give adjuvant radiation therapy. Scenario 2, you can consider a radiation therapy more than 3 mm. Scenario 1, based only on PSM, you can avoid giving it. Now, RAVES and Radicals trials which evaluated SRT versus ART, they said that SRT is equivalent, if not bad, than ART. So, but the important thing in that was that most of the patients, 80% of the patients were not having a combined like T3B or T4 and Gleason grade group 4 and 5. Only 20% of the patients had that. So that was not powered to evaluate that subset of patients. So, and positive surgical margins, whether there or not, so those patients in effect might need adjuvant radiation therapy. So, thank you. I will request Dr. Gopal to discuss our results.
Thank you very much, sir. So I will just give a brief synopsis of, I think we had enough of Western literature talking about positive surgical margins. So quote unquote with many limitations of our data set. First of all, we had about 1100 patients of radical prostatectomy. I was able to include only 683 patients who had available margin data and BCR data. So of these patients, of 683 patients, about 1/3 had positive surgical margin. So standard literature on this data is up to 10 to 20% positive surgical margin, and of that, about 15% had multiple surgical margin positivity. The mean duration of follow-up is about 18 months. So you can see that from clinical stage T1 to T4, the margin positivity rate increases, but as you would see that in clinical stage T2, the margin positivity rate is 41% and as compared to PT38. And before you ask any question, I would like to let you know that in our data set, in patients with clinical T2 stage, there is about 40% chances of upstaging and upgrading. So we have already published a paper on this. So that's why that is the reason I would like to quote here why the margin positivity rate was higher in clinical stage T2. But now again, the data is quite standard for margin positivity rate in T2 to 3B. So margin positivity rate increases as you go beyond. So this is basically just to show you whether the positive surgical margin is iatrogenic, that is because of surgical technique, or whether it is because of the disease itself. Now our data for T2 disease, which is quite standard as compared to the current literature, which is about 10 to 15% for clinically localized prostate cancers. So biochemical recurrence rate was obviously significantly higher in patients who had margin positivity. The p-value for this was less than 0.00. And so we had also made Kaplan-Meier curves, and we could see that this margin positive line is going well below the margin negative line. So p-value here was less than 0.01. And then we had again tried to evaluate patients with multiple margin positives versus single margin positive. So again, the p-value was significantly favoring the survival in patients who had single margin positive as compared to patients who had multiple margin positive. And now we have not considered other factors which could have influenced the survival data. That is, we have not considered Gleason score and clinical stage here. So with this, I would like to thank. If there are any questions, we would be happy to answer. Thank you.
So, yeah, so the very good presentation, and a couple of points I'd like you to elaborate a bit more. Now, Puneet was alluding to this a bit earlier, and that gentleman, Dr. Mujib was also talking about this. Would you give radiation to all people with margin positivity, was the question that was asked. And now, a pragmatic approach would be to, anyway, you cannot give radiation before the leak stops for the patient, yes? And that's going to take anywhere between 3 to 6 months for the leak to stop. And now we know from all the RCTs that adjuvant radiation and salvage radiation, out of which salvage seems to be early salvage, early salvage seems to be a bit better. So with that being the case, why would you think of giving adjuvant RT to all people with positive margins, right? There is no reason to do that. And also, you need to wait for a particular time before the leak stops. You don't want the patient to, also early radiation would give you bladder neck contraction, all sorts of stuff, right? Your best is to wait, give them a chance to see the PSA, how it develops, how it forms, and then go in and give them salvage radiation. I'm going to ask the experts to weigh in on this as well. So I would like to you to answer this, and Dr. Mujib, just 20 seconds for you to answer your point of view.
So I totally agree, sir. We don't give radiation to all patients with positive surgical margins. Only in the subgroup, which I said was the T3B and Gleason grade group 4 or 5, and multifocal positive surgical margins, those are the group. And the RCTs which we are talking about, raves and radicals and all. So if you see, there were 10 to 20% of the patient who had all these factors. And they have mentioned specifically that this RCTs were not powered enough to give recommendation on that particular subgroup. So SRT, which is early salvage RT, which is equivalent to ART, is for the rest of the 80% of the patient, but in these patients you can actually consider adjuvant radiation. Now the second thing is that yes, practically patient is having a leak for 3 months, so you have to wait, and you have to wait for at least 3 months. Usually at 3 months time patients improve continence, but the question is that if at the time of 3 months if the PSA is still less than 0.1, and you have all these features, multifocal positive margins and T3B disease and Gleason's grade group 4 or 5, then do we give radiation or not to those patients?
I think to answer your question, any subgroup, right? You will not be wrong if you do a early salvage RT. In the era of hypersensitive, supersensitive PSA and all that.
So early salvage means PSA still have not
You
crossed
don't
0.1.
need to wait for 0.2.
0.1 I'm saying.
If you see an upward trend from the day you're starting with, then I think it's reasonable to go into salvage
No,
radiation.
the question what he's asking is actually pertinent to everyone, that you have, say, multiple positive margins and no other abnormal features, and you keep on doing PSA. It is undetectable for quite some time, 3 months, 6 months, 8 months. Then what would you do? That is the question which
No, sir,
requires to be
if
answered.
there are no other features, even multifocal margins, PSA is normal, you don't do anything.
Correct. So
If
that is what is a clear message.
That's the
That
point.
in isolation, positive certical, multiple margins will not be the clear-cut radiation unless and until the PSA
Exactly right.
starts
So
rising.
the pathology, unless you leave a big chunk of prostate inside, does not determine your need to immediately give them adjuvant radiation. You wait, follow them up, look at the PSAs, and then take a decision.
Correct.
Yeah.
The other point which needs to be considered
We
is
need to,
where...
we need to please, can we discuss this at lunchtime because we are starting late?
Yeah,
Okay.
sure.
We can now invite, the next session is on BCR. Ashwin Tamhankar is probably not, Dr. Anil is probably doing the presentation. Yeah, yeah. And yeah, the chairman remain, yeah.
Good morning, everyone. I thank our organizers for this opportunity. I'm Dr. Anil Kumar T from Bengaluru. Now we shall discuss biochemical recurrence after local therapy for carcinoma prostate, may it be post-RP scenario or post-RT scenario. What is BCR post-RP? It's a PSA value of more than or equal to 0.2, and the same value has to be there after second repetition. Initial postoperative PSA should be done at least 6 weeks after the surgery because we should allow it to wash out for the residual serum PSA. And second measurement is also necessary to rule out by laboratory error. According to Pound et al., 20 to 40% of the patients develop BCR within 10 years with a median of 20 to 38 months. These patients with BCR are around 24 to 34% at clinically evident metastatic disease within 15 years of surgery. So factors associated with distant metastasis after BCR are PSA doubling time of less than 3 months, PT3B disease, Gleason score of 8 to 10, and biochemical recurrence within 3 years after surgery. Hellman et al. Showed that there was no difference in BCR outcome between open radical prostatectomy and robotic radical prostatectomy. However, meta-analysis by Lee et al. Showed 59% risk reduction in robotic-assisted radical prostatectomy group compared with laparoscopic group. So I shall be using some case scenarios from now on to have a discussion on BCR. This is a 57-year-old gentleman post robotic prostatectomy in March 2022. Pathological staging was PT2N0, margins were negative. Initial PSA was 14. On follow-up, PSA was undetectable. On follow-up, later follow-ups, his PSA started rising after a year, and it was 0.1 initially, and after a month it was 0.26. So, what are the available options for imaging in such patients? Whether it's just MP-MRI, PET-CT scan, or combination of both this. So patients with low risk of metastasis, just MP-MRI is enough for localizing the recurrence in prostatic bed as well as pelvic lymph nodes, which are the initial harboring sites for metastasis. So moreover, it also helps in guiding the biopsy and adding salvage treatments. So patients with high risk of metastatic disease, both MP-MRI and whole body PET-CT is required. What is the rationale for using this PSMA PET-CT? When PSA, it was seen that when PSA was 0.5 or less than it, positive lesions were found in 48% of the patients using this PSMA PET-CT. And when the PSA was between 0.5 and 1, positive lesions were found in 73% of the patient. And also it changed management in around 39% of the patients. So combining imaging modalities, they are the more effective in detecting recurrences. If you look at this chart, even when the PSA was 0.2, PSMA PET-CT could detect recurrence in 33% of the patients. And when PSA was more than 2, the positivity rates increased to 95%. So what's next? Whether all the BCR needs to be treated? If so, radiation, whether it can be used in adjuvant or salvage setting, what is the timing, dose, field of radiation therapy, whether hypofractionation can be used in the setting of BCR, whether it should be used with or without ADT, duration of ADT if it's used, whether short or long term, and the role of salvage lymph node dissection shall also be discussed. Salvage therapy reduces the distant metastatic development and also improves prostate cancer specific mortality. Early salvage therapy lowers the risk of distant metastasis, cause specific mortality and overall survival at 5 and 10 years. So treatment with salvage radiation therapy reduces threefold prostate cancer specific mortality when compared with other group, and the 5-year biochemical rate was around 56%. So salvage radiation therapy, when it was given in, with the low PSA values, it improved biochemical recurrence. Earlier the salvage radiation therapy, more effective it is. If you see all these trials, may it be radicals, raves, GETUG, or even artistic meta-analysis, these showed that 5-year biochemical progression-free survival was almost equal with both the arms, like adjuvant radiation therapy or salvage radiation therapy, or even better than that. So when should we start treating this patient? Whether at PSA level 0.1, 0.2, 0.5, or 1. More than 60% of the patients which are treated before PSA level more than 0.5 will achieve 80% chances of being progression-free in the next 5 years. That means these patients should be treated before the PSA level reaches 0.5. So what is the dose of salvage radiation therapy that can be used in such patients? According to SAC 0910 randomized trial, which compared 64 gray in 32 fractions, 70 gray in 35 fractions, it supported use of 64 gray in 32 fractions or equivalent shorter fractionation as a standard to treat these patients. Also, the EOTC trial used 60 gray in 30 fractions in the adjuvant setting and showed that there is substantial improvement in biochemical control after radical prostatectomy. Whether we should just irradiate the prostatic bed or we should include pelvic nodes also is the question. Pelvic node, lymph node metastases are the common site of recurrence after salvage radiation therapy just to prostatic bed. RTOG trial, which included radiation to prostatic bed along with pelvic lymph nodes, showed that 5-year freedom from progression was improved by addition of pelvic lymph nodes into the radiation therapy group. Also, pelvic nodal radiation was tolerated with a modest increase in grade 3 plus toxicity. Whether hypofractionation can be used in such scenarios? Conventional RT usually takes over 7 to 8 weeks to it be completed, and that also limits its use. Technological advancements like IMRT, IGRT can enable dose-escalated treatment with high precision with hypofractionator approaches. Some small studies shows conflicting data. However, initial data from larger trials appears to be promising and can be used nowadays. So pelvic lymph nodes are a common site of recurrence after salvage radiation therapy to prostatic bed. Whether all the patients with BCR needs to be treated with radiation therapy? It might be a overkill. Decipher helps to guide decision to treat use salvage radiation therapy in patients with BCR. It is a 22-gene expression assay, and it predicts 5-year risk of metastatic CA prostate. When the Decipher score is less than 0.4, only 10% develop metastasis within 3 years of biochemical recurrence. When it was more than or equal to 0.4, 73% develop metastasis, out of which 40% developed BCR within 3 years. So when it comes to ADT, whether it should be used, it should be used very early or late. Early initiation is more beneficial compared to delayed initiation. However, the side effects remain high. Guidelines recommends other factors including PSA velocity and doubling time when selecting patients to use ADT along with RT. Consideration can be given to intermittent ADT, that is a cycle of 8 months, followed by observation, and then restarting ADT when the PSA reaches more than 10 nanogram per deciliter. Those treated with intermittent ADT also reported better quality of life. These two trials, GETUG and RTOG, they used ADT along with RT, and then those showed that better progression-free survival, better metastatic-free survival, and also better distant metastasis and disease-specific mortality also. So TOE trial compared immediate ADT versus delayed ADT, and they showed that there is no difference between prostate cancer-specific mortality. However, there was time to distant progression and also local progression was deferred in immediate ADT group. Radicals which compared no ADT, 6 months or long-term ADT also showed that 6 months ADT did not improve metastatic-free survival. When 24-month ADT was given, metastatic free survival was improved, and also time to delayed ADT was also delayed. What is the role of salvage pelvic lymph node dissection in such scenarios? It can be a reasonable alternative to ADT because ADT itself is not a curative treatment, and there is significant toxicity associated with it. When salvage radical lymph node dissection is used, there was 35% recurrence-free, patients were 35% recurrence-free at 5 years, as shown by Rigatti et al., and also 42% of the patients were symptom-free at 3 years, as shown by Gillig et al. In this cohort of study, when salvage lymph node dissection was done using PSMA-guided surgery, 2-year BCR recurrence-free survival was around 32%. However, there is no high-level evidence for oncological value of using salvage lymph node dissection. This is the second case, 63-year-old gentleman, post-robotic prostatectomy with initial PSA of 18, final histopathology PT2 N0. At 36 months, PSA was normal and then it started rising. It was 0.18. PSMA PET-CT was done at that time. It didn't show any uptake anywhere. So where can be the recurrence when PSA is not showing, PSMA PET-CT is not showing anywhere? Local recurrence will be most commonly at the vesicourethral anastomosis junction or anterior or posterior bladder neck. So this patient falls under EAU low risk BCR category when the PSA doubling time was more than 1 year and also ISUP grade group was less than 4. In such patients, what was the level of PSA to initiate salvage RT? When 5-year biochemical recurrence-free survival was seen, 71% of the patients had biochemical recurrence-free survival after early salvage radiation therapy. However, when PSA was less than 0.5, when PSA increased more than 0.5, around 46% of the patient had 5-year biochemical recurrence-free survival, around 30% dip when PSA rose more than 0.5. Hence, salvage RT should be initiated before PSA rises more than 0.5. This is our third case, a 66-year-old gentleman referred by another urologist. Post-URP, the prostatic chip showed cancer. Clinical staging MRI showed clinical T2 disease, N0 disease. Bone scan was negative. Since patient came with bone scan and MRI, PET-CT was not done. He underwent robotic prostatectomy. 6 weeks later, PSA was repeated and it showed 3.9. It was a shocker to us. What went wrong? Why conventional imaging is not sufficient for staging? PSMA PET-CT has 27% greater accuracy when compared with conventional imaging. Conventional imaging has low sensitivity, around 38%, and specificity 91% when compared with PSMA PET-CT. Hence, PSMA PET-CT should be a suitable replacement whenever and wherever it's available. Also, the Empire 1 study demonstrated improved biochemical-free survival when molecular imaging was used compared with conventional imaging. Oriole trial also demonstrated that when PSMA positive disease was not included in treatment plan, these patients experienced recurrence faster compared with other group. So in the next case scenario, this is fourth case where a 66-year-old gentleman underwent robotic prostatectomy, final histopathology was PT2, margins were negative. There was a single bony lesion on the right rib cage on PET-CT. Hence MRI was done, which showed it has a whole heel rib fracture. Till 10 months, PSA was within normal limit, non-detectable. At 15 months, it was 0.28. PET-CT was done at this stage. It showed the same uptake in the right rib, but no other lesions anywhere. So PSMA can be positive even in non-metastatic bone lesions, like osteoarthritis, degenerative changes, fibrous dysplasia, healing fractures, and after radiation therapy and also Paget's disease. Gold standard to prove whether it's metastasis or not is only by histology. It's often impossible and also extremely difficult to biopsy that lesion. And indirect validation is regression of the lesion with PSA decline after using targeted therapy. So these patients received ADT plus early salvage RT to the prostatic bed and pelvic lymph nodes. And after a year, PSA is still undetectable in this patient. The SPORT trial, which included RT to the prostatic bed, RT to along with pelvic lymph nodes and also inclusion of ADT. This showed that the arm which had RT to pelvic bed and also pelvic lymph nodes and use of ADT that group had better freedom from progression compared to other two groups. This is another case scenario where a 64-year-old gentleman underwent robotic prostatectomy. Finally, clinically T3B disease. One dose of ADT was given elsewhere before coming to us. He underwent robotic prostatectomy one month after he received the injection. Initial PSA was thought to be controlled, but after 9 months, it started rising and it was 0.9, 0.5. PSMA PET CT was done at this stage, which showed tracer uptake in the bladder neck region. In such scenarios, whether we should go directly to give ADT plus RT, or we can do prostatic biopsy. Where does the biopsy of the recurrence stand? Trust-guided biopsy can be done, but in PSAs less than 0.1, only 24% at positive biopsy. The limitations being the positivity rates are just between 38 to 55%, and majority required need repeat biopsy. A positive biopsy does not rule out metastatic disease, and a negative biopsy also does not rule out local recurrence. So coming to biochemical recurrence post-RT, Astro defined it as 3 consecutive rises in PSA after the PSA reaches post-RT nadir. But there was a lot of criticisms and this was not accepted, hence Phoenix criteria came, which defined PSA value of more than or equal to 2 nanogram per deciliter above post-RT nadir. It is the most commonly used one. When BCR happens after post-RT, BCR is seen in 15 to 57% of the patients after post-RT, and 1/3 of these patients progress to metastasis and die of prostatic cancer. This is the table where there have been criticism points. Hence, Phoenix definition is so called because it rose from the ashes of Astro, and it's defined in Phoenix, Arizona. What are the factors predicting prostate cancer progression post-primary RT? It's high Gleason score, shorter interval to biochemical failure, shorter PSA doubling time, higher clinical T stage, and high PSA value prior to RT, and higher nadir PSA value after primary RT. These are the factors predicting cancer progression. So this is a RT scenario. This is a 70-year-old gentleman who received primary RT and ADT 2 years back. This was the left side image. PET CT is the 2 years back image. A localized tumor, clinically 2 TC, N0. PSA was normal for 34 months, and he achieved nadir of 0.1 nanogram per deciliter. After 3 years, when PSA started rising, it was 3 nanogram per deciliter. He didn't have any symptoms. What next? Prostate biopsy is required. If it's required, what is the technique? And what are the imaging modalities available in such patients? Prostatic biopsy after primary RT is used whenever there is biochemical failure. Histological confirmation of local recurrence is always required when you are considering salvage treatment in such patients. The biopsy helps to detect local recurrence, persistent of prostate cancer, and also evaluate the grade and extent of local extent. Indeterminate biopsy can be seen most commonly and shortly after radiation therapy, and it's seen in around 40% of post-radiation biopsies. False positivity also can be seen because the radiation effects takes a lot of time for it to happen on the prostate cancer cells, and it might take around 30 to 36 months following RT to kill the cancer cells. So in patients who have early BCR, post-RT, biopsy should not be delayed in such patients because they are at the highest risk of prostate cancer progression, and they are the patients who likely benefit from early salvage therapy. Negative post-radiation biopsy
Dr.
in presence
Anil,
of BCR.
Can you sum it up fast?
Yes, done, sir. Another 2 slides. Negative post-radiation biopsy in presence of BCR, repeat biopsy should be done. Image-targeted biopsies are done usually with MP-MRI, novel PET CT, or PET MRI. There's this 3-dimensional template mapping biopsies, which is reserved for patients which does not have target on imaging, and also in patients with previous negative biopsy. So technique is that both transperineal and transrectal biopsies can be used. Typical 12-core sampling biopsies along with cores should be taken from the base of the seminal vesicles, distal ends of the seminal vesicles, distal apex, and the medial biopsy should be closer to the urethra. So there is this meta-analysis by Zamboglu et al. Which showed MP-MRI as high specificity but limited sensitivity in such scenarios. So use of PET CT along with MRI can improve sensitivity, specificity, and localization. So what are the available salvage treatment options in such patients? Salvage radical prostatectomy, salvage ablative therapies, cryoablation or IFU, and second repeat RT with SBRT, brachytherapy or EBRT. When salvage radical prostatectomy is used compared with open RP.
Can you please cut short this?
Yes, yes. It has higher risk of all the complications and should be used judiciously in patients with low comorbidity and life expectancy of more than 10 years. Local recurrence and low volume metastasis, local salvage therapy along with metastasis directed therapy can be treated. This is a sum up of all what I have told right now. So last but not least, there is no common agreement as to what constitutes BCR after IFU. Different definitions has been proposed. Finnish definition is one and Stuttgart is one. So these are the take-home messages. PSMA PET CT should be the imaging of choice whenever available, along with MRI. Salvage radiation therapy should be used before PSA reaches 0.5. BCR after radical prostatectomy include pelvic lymph nodes along with prostatic bed for RT in high-risk cases. Early ADT initiation and long-term 2 years of ADT for high-risk BCR patients. Single bone metastasis, MRI or biopsy to prove whether it is actually metastasis or not. Prostatic biopsy after primary RT should be done when considering salvage treatment. Salvage treatment for biochemical recurrence post-RT still associated with higher risk of complications. Thank you.
So, thank you, Anil. It was a nice presentation and a variety of cases which you have shown. I think the last slide of take-home message is very crisp and clear. So, and it gives us the message regarding the time to intervene after biochemical recurrence, which modality of investigation and the radiation. Can you comment on the ultra-sensitive PSA, which has been coming now, so that one can know about the biochemical recurrence even before the PSA shows? Any comments on that?
Yes, nowadays ultra-sensitive PSA can, along with the decipher, what I mentioned, that can predict which patients can undergo salvage before recurrence. Because PET CT is only positive in 33% of the patients. We can start giving salvage therapy at the site of recurrence, which is most commonly in the prostatic bed, before and itself, in high-risk cases, depending on what are the high-risk criteria used.
Even now, even microRNAs are also being used. So these molecular markers are being used in association with the rest of the clinical scenarios.
Yes.
Thank you, Dr. Anil. We move on to the next
Thank you, sir.
talk, Management of Lymph Nodes by Dr. Sanjoy and Dr. Sumit Mandal.
Can we request the panel to also the speaker to restrict the talk so that we can have a 5-minute interaction? The whole purpose of this session was having interaction, not a classroom presentation, please.
Amit, you had to instruct them to give it for 15 minutes because now the timer will be for 20, so they have timed it for 20.
The timer will be at 15 now so that we can have a session. Unfair to Sanjay, but he'll manage.
Thank you for giving me the opportunity. It's always privileged to talk in front of so august gathering. So, in the
now time for that, isn't it?
In the gala dinner time, when we go in front of this bar with our colleagues, we always remain confused. कि आज पीना है कि नहीं पीना है? अरे कौन सा पिए? हाँ, ये after 2-3 पैक तो कुछ भी पी सकते हैं, dilemma खत्म हो जाते हैं. So, with this dilemma, I try to find out ways to finish the dilemma today or tomorrow. So, if I want to ask the panelist, the chairperson, so what do you think the dilemmas in management of prostate cancer lymph node? I just want to clarify. Here I will discuss regarding the management of localized prostate cancer and the lymph node management in that setting. So, Dr. Anand, what do you think? What are the dilemmas in your mind?
I think with regards to what the guidelines say and what is done in practice, there is a big difference. I think a lot of us, when we're doing radical prostatectomy, don't do a complete extended lymph node dissection. And I personally don't think it's needed, right? Most of the times it's not needed. And it is not a curative type of thing. It's only for prognostic purpose. There is no situation or a very small percentage of people may benefit in terms of extended lymph node dissection, but the rest of it is only for prognostic prognostication of that disease.
Sir, any of you think something different, dilemmas in your mind while you are dealing?
If it's a localized and a low risk, do you have to do it? You don't have to do it. In all patients, do you do lymph node dissection or you don't do lymph node dissection? These are the dilemmas.
I think in our scenario, lymph node dissection is done in every patient. Because from
Even
our
after PSMA
perspective-
PET? Even after PSMA PET?
Even after PSMA PET.
Why?
And even after MPMRI, because almost 30 to 40% of the patients which you consider to be T2 disease eventually will turn out to be T3 disease. And therefore, removing that lymph nodes of obturator and small groups of lymph nodes on both sides doesn't add the time as well as the morbidity. That's our philosophy.
But does it add to the cure is the question.
So it gives the prognosis, the staging. Not it is, as you rightly said and everybody said, not for the therapeutic purpose, but to understand what exactly is this stage, because PSMA PET and whatever you do, eventually if it is T3A or T3B, a lymph node status, once you remove those.
But why extended?
Okay,
Not
so
extended. It's only the small group of lymph nodes, obturator and the extrailiac on both.
So during last month's EAU, Declan Murphy from Melbourne, he presented his data, and he said that virtually the lymph node dissection for prostate cancer is going to be obsolete because it has got no role to play.
So let us see what the evidence is. So as I discussed, why there is dilemma, as Dr. Anand said, the practice pattern for lymphadenectomy is varied from region to region, guidelines to guidelines. And if you see in the largest few data from like US, their lymphadenectomy, standard lymphadenectomy in managing localized prostate with variable prostatectomy is approximately 60 to 65%. The UK data is same, but if you see the Germany, Netherlands and all countries, their lymphadenectomy is up to the tune of 90 to 95%. And we don't have any national database to say that what is our practice pattern. And again, as said, the extended, standard, the definition is very varied. Maybe in some literature or for some group of countries, region, they use extended for a standard term, and there are variation. And as said, there are therapeutic values are not very clear. And those who are not doing lymphadenectomy in very low risk or maybe favorable intermediate risk, they are saying it only add morbidity, nothing else. So yes, whether we should do it in all patient or in no patient, so all and none law does not follow here. Maybe we should do in selective. What should be the extent? If we are doing, whether it has had any therapeutic value or not, whether there is any role of sentinel lymph node biopsy in prostate cancer setting, whether we should do antegrade or retrograde, is there any role of unilateral lymphadenectomy in a very specific localized unilateral disease, whether if we are doing a radical prostatectomy and there is a biochemical recurrence with a lymph nodal disease, whether role of salvage lymphadenectomy or not, whole prostate radiotherapy, or we should include the lymph node when we are giving radiotherapy as a primary modality. So these are the questions when we talk about the dilemmas in management of prostate cancer, lymph node in localized prostate cancer. So I will invite Dr. Sumit to take one question, and he will go through the evidences to let you make little more wiser. And finally, after his evidence, I will talk how to satisfy, and you can be sure what to drink and get high in the evening.
Thank you, sir, and thank you everyone for the opportunity. So at the outside, let me speak about the different risk stratified approach of low risk and intermediate risk and high risk as per EAU classification. And today we are going to focus on the localized prostate cancer only. So the lymph node percentage respectively for low, intermediate and high risk are less than 2%, 3.1 to less than 20% and more than 20% respectively. And the therapeutic recommendations are for low risk is no PLND. For intermediate risk, use a nomogram and then decide whether to do or not. And for high risk, perform a EPLND. So even the NCCN guidelines for very low risk, they don't talk about surgery itself. For the low risk, even if radical prostatectomy is done, no lymphadenectomy is to be done. In favorable intermediate risk group, again, use the nomograms and decide whether to do or not. For unfavorable intermediate and high risk and very high risk, to include the pelvic lymphadenectomy. So all in all, almost all the guidelines basically say take a risk calculated approach and decide whether to do a lymphadenectomy or not. But if you look at the, try to search which particular method to find out the risk stratified approach, there are more than 200 nomograms in PubMed. So which one to follow? Let me just quickly touch up to them. Partin table, as we know, the oldest one, G, T, and P, the Gleason T stage and PSA. Roche nomogram, which is the derivative of Partin nomogram. Briganti nomogram, this is one of the nomogram which has been updated multiple times in 12, 17, and 19, where they had stressed out on the percentage of the positive course as an important factor. MSKCC nomogram is very easily available. They also have some disqualifying questions and some general information. And Gangdalia et al. Updated the nomogram based on MRI findings. So we have MRI-based nomograms also to predict the lymph node invasion. And if you, and the comparative analysis, almost all the nomograms perform equally. Sometimes one nomogram or the other performs better, but one can stick to any one nomogram and continue with that nomogram. Even PSMA-based nomograms have also come, known as Amsterdam, Brisbane, Sydney nomogram, and on the decision curve analysis, it performed better than those nomograms, which has been recently externally validated with one of the studies in JU. Machines are not very far behind, and they are also coming up with comparable accuracy. It may be a matter of time they take over it, so that's something to wait on it. The question arises, how much to do? So classically, the templates that we follow are the limited, standard, extended, and super extended. And the respective lymph node packets are obturator and obturator plus external in standard, obturator and external internal in extended, and anything more in super extended. But sometimes there are different schools of thought also, where the limited, they tend to include the external iliac with obturator in the limited, and the entire thing shifts up by one slot. So it may be a better thing while doing a lymphadenectomy to suggest which particular lymph node packets are removed or which particular groups of lymph nodes are removed. Whether e-PLND is better than standard PLND, yes, on a retrospective systematic review, there was a slight difference, but then look at this. These are the 4 studies which were prospective studies, and they did not have any survival advantage. But do we have any level 1 evidence? Yes, we have 2 studies which were published in 2021. Quickly going through them, the study by Lessing et al. Who randomized almost 300 patients into limited as well as extended nodes, and they overall did not find any survival outcome, but in the subgroup analysis they found that e-PLND had a better biochemical recurrence-free survival. However, there was interaction also, but that was their finding. So as surgeons, we sometimes want to do more for the patient and sometimes less is more, but then it's all